Welcome. Welcome, my dear friends. Myself, Professor Dr. Rajendra Raghuvir Deshpande, would like to welcome you all in my Ayurveda Academy YouTube channel. As you know that I am MD in Ayurvedic Medicine and MD in Ayurvedic Physiology. For paid online consultation, you can definitely WhatsApp on 9226810630. My dear friends, today we are again going further for the clinical examination of motor system part 2. All these actual demonstration videos are available on my channel, that is Ayurveda Academy. Please check the playlist, that is clinical examination. Second important good news. Now all these my videos will be available in the multiple subtitles like Marathi, Hindi, English, Gujarati, Odisha, German, all the different languages you will get the subtitles. So please check your subtitle adjustment and make it on. Then you can hear my voice in Hindi, English, dubbing voice in the different languages. So whatsoever language of my video now, whether it is Marathi, Hindi, English, nothing to be worried about. Everything is available in different languages, subtitles, and also audio. Let us start to discuss about these motor system, nervous system examination. So here we are going to discuss abnormal movements, posture, and reflexes. Please check whether you have seen my first part, because motor system part 1 is already uploaded. You have to check that video. So what are the abnormal movements? Abnormal movements means involuntary muscular contractions of various types. So this is involuntary muscular contractions. The first thing the doctor should note whether the movements are widespread or they are only localized. Only one hand, only one leg, that is localized. But both the hands, both the legs, that is widespread problem. So these are the different abnormal movements. Number one, spasm. What is spasm? Spasm, commonly you know that bronchospasm in the bronchial asthma, but muscle spasm is very common, especially the gastrocnemius muscle spasm is there and back muscle spasm is there. So what is spasm? Spasm is an exaggerated and involuntary muscular contraction. It may be tonic or it may be clonic. So what is tonic and what is clonic? Tonic means muscle stiffening and clonic means rhythmic muscle jerking. Tonic is stable, stiff, and clonic is jerky movements. Okay, like a spasm. Next abnormal movement is fasciculations. Fasciculations are clonic contractions of isolated muscle fibers, like clonic fasciculations. Then chorea, abnormal movement, third movement, chorea. Chorea means apparently purposeless, jerky, and irregular movements which are increased by emotional tension and are absent. Chorea is always absent in the sleep. Now, fifth abnormal movement is athetosis. Athetosis means slow snake charming movement seen especially at small joints of hands and wrist. Slow snake charming movement, that is athetosis. Next abnormal movement is hemibalismus. Hemibalismus. Hemibalismus means violent, flinging, abnormal movement of the extremities on one side of the body, either right or left. But these are not common. I will tell you which is the common. Commonest is a tremor and the spasm. These abnormal movements are very common when the patient comes to us. I repeat, spasm is common, tremor is common. Okay, so what is tremor? Tremor means to and fro, rhythmic oscillations of fingers, of outstretched hands, or of tongue, head, or the lips. But basically, these outstretched hand tremors are very common in hyperthyroidism. Senile tremors, because of the old age, tremors are common in the old people. Now we will discuss about posture. Position of the different body parts adopted in relation to one another and in relation to the surrounding, that is called as a position. There are typical postures of different diseases. Abnormal postures are seen when proper control of muscle tone and movement is affected. Now let us see the different positions. In hemiplegia, the paralyzed arm is adducted, the forearm is flexed and pronated, and the fingers and the wrist are flexed. The hip is also adducted and the knee joint extended. So this is typical position of hemiplegia. This may be asked in the oral examination. In the paraplegia, that means the paralysis of both the legs, the knee joints are either flexed or extended. The examiner will ask, what is decubitus? Decubitus means position adopted by the patient during lying down in the bed. That is decubitus. Now, next point in the motor system examination is gait. What is gait? Gait is the position adopted while walking. Gait in different diseases is almost diagnostic, spot diagnosis, and therefore must be noted when the subject, that means the patient, enters the room of a clinic and walks up to the examination table. The doctor should closely observe how the patient is walking. The typical examples of gait are: number one, circumduction gait in hemiplegia. Circumduction gait in hemiplegia. Seizure gait in diplegia. Propulsive gait or short shuffling gait in extrapyramidal lesion. High stoppage gait or stamping gait in sensory lesion. Drunken man's gait in cerebellar lesion. Lesion means either bleeding, thrombosis, embolism, trauma, etc. Waddling gait in pregnancy and hip disorders. So these are the different photographs. You can see circumduction gait. This is the drunken gait. This is the Parkinson gait. This is the polio gait. Again, I request, please check list of my channel about clinical examination. You will get fantastic videos of nervous system examination, cardiovascular system examination, pulse examination, respiratory system examination, artificial respiration. Superb videos, superb. Lot of views are there, lot of likes are there. So don't miss it. Okay, and let us move. So these are the abnormal gaits. For example, spastic gait, seizure gait, propulsive gait, stepping gait, and waddling gait. Let us see scissoring gait, crossed leg gait. This scissoring gait is seen in cerebral palsy and paraplegia. Legs are crossed due to the adductor tightness. Now we will go further. This is the examination of reflexes by clinical hammer for the deep reflexes. First question in the examination, what is reflex? Reflex is an immediate and involuntary motor or visceral response to an afferent sensory stimulus. Now, first we will see superficial reflexes. Regarding eyes, corneal reflex here asks the patient to look at a distant object, touch the cornea with a sterile wisp of cotton wool from the side. Bilateral closure of the eyes will be the response for this corneal reflex. Now, conjunctival reflex. Ask the patient or volunteer to look at a distant object, touch the conjunctiva from the side. Bilateral closure of the eyes will be the response for conjunctival reflex. Can you see wisp of the cotton? And we are touching over here cornea and the conjunctival reflex, and next will be the corneal reflex. Okay, superficial reflex. Next is a pharyngeal reflex. Ask the patient or volunteer to open his mouth, touch the pharyngeal wall or the tonsillar fossa with a tongue depressor. Muscles underneath contract, resulting in contraction of pharynx. Next superficial reflex is a palatal reflex. Touch the mucous membrane covering the palate with a tongue depressor. Elevation of the soft palate will be the result of this palatal reflex. Can you see tongue depressor in the hands of Dr. A.R. Joshi sir, my teacher, my guru all the time for the subject physiology. Okay, so you can see he is doing the test on his volunteer. Next, abdominal reflexes. Now, this in bracket root value is very important. These are the nerves coming out from the vertebral column, spinal nerves, and they are doing the job of giving response with that reflexes. So thoracic 7 to thoracic 12 are the originality over there, because if the damage is over here, then abdominal reflexes we will not get properly. Gently stroke the skin of abdomen with the blunt end of the percussion hammer in the area where doctor wants to elicit the reflex. Stroke should be directed towards the umbilicus from all directions, but never radiating from it. Contraction of underlying muscle is observed, that is abdominal reflex. Can you see? From periphery to the umbilicus, not from umbilicus to the periphery, from here to here. Can you see the cursor? Okay, abdominal reflex. Next, superficial, most important is a plantar reflex. The root value is lumbar 5, sacral 1 and sacral 2, L5, S1, S2. These values are very important to remember because original pathology is happening over here. Plantar reflex is also called as Babinski's sign. The doctor should see that the sole is dry and warm, sole of the patient or volunteer. With the sharp end of the hammer, start stroking from the lower lateral border of the sole at the base of toes, turn medially and proceed further up to the base of great toe. All demonstrations are available on my channel in the playlist of clinical examination. The plantar flexion of the great toe is a normal response. When there is a dorsiflexion of great toe and fanning of the toes, the response is called as Babinski's sign, which is always present in meningitis. Remember, this meningitis is an inflammation of meninges. So Babinski's sign positive, neck rigidity, very high temperature, headache, and projectile vomiting are all together the symptoms and signs of meningitis. Okay, so that is related with Babinski's sign. Can you see clinical hammer? And from lateral side to the medial, the Dr. A.R. Joshi sir is expressing the Babinski's sign. Now, we will start with the deep reflexes, which are also called as a stretch reflexes. First is jaw jerk, and the root value, the original nerves are in the pons. Ask the patient or volunteer to keep the mouth partially open with jaw muscles relaxed. Keep the index finger over the chin and percuss the hammer. There is a partial closure of the mouth, that is jaw jerk. Next is a bicep jerk. Here, bicep muscle. Cervical 5 and cervical C, these are the root values, very important. C5, C6. Elbow is flexed at right angle. The forearm is slightly pronated and supported on the examiner's forearm. The thumb is placed on the bicep tendon to fix it. and percussed with a hammer. The contraction of bicep is either seen or felt. Next is a tricep jerk, which is also deep reflex, C6 to C8. These are the root values, cervical 6 to cervical 8. The forearm is flexed at right angle and supported at the wrist. The tricep tendon is struck with the hammer just proximal to the olecranon process. Extension of the elbow will be seen. This is tricep jerk. Next is a supinator jerk, here wrist. Supinator jerk, C5, C6. The forearm is flexed at right angle and is in the mid prone position. Support it at the wrist and strike the tendon at styloid process of the radius with a hammer. There is a flexion and partial supination of the forearm. Next, this is a demonstration of tricep jerk, C6, C8. These are, and Dr. Ayurveda sir is showing how we can see the partial contraction of the tricep muscle. Next is a wrist, that is a supinator jerk reflex. Dr. Ayurveda sir is showing around, this is the wrist and he is doing the tapping with the hammer. Now we will talk about the deeper reflexes in the lower extremities. First is a knee jerk. The root value is lumbar 2, lumbar 3, lumbar 4, L2, 3, 4. Ask the patient or volunteer to cross one leg over the other and allow the upper leg to hang loosely. Give a sharp tap on the patellar tendon with hammer. Extension of the leg and contraction of the quadriceps is seen, that is knee jerk. Can you see the picture of the knee jerk? How Dr. Ayurveda sir is expressing or showing, delivering to how to take the knee jerk. The root value is L2, L3, L4. Now next deep reflex is ankle jerk, which is having the root value that is L5, lumbar 5, S1 and S2, sacral 1, sacral 2. Ask the patient or the volunteer to kneel with one leg on a chair. Slightly dorsiflex the foot and give a tap on tendo achilis with the hammer. Plantar flexion of the foot is observed. For doing the ankle jerk in lying down position, cross the leg to be tested over other leg by flexing at knee and by slightly dorsiflexing the foot. Give a tap on the tendo achilis with the hammer. Plantar flexion of the foot will be observed. If the knee and ankle jerks are exaggerated, patellar and ankle clonus can be elicited. This is ankle jerk. Dr. A.R. Joshi sir is demonstrating how the position of the leg should be kept. You can note very carefully. Now, this is the case paper that you have to fill. Superficial reflexes, the name of the patient, then naturally the age of the patient, then posture is normal, decubitus is normal, gait is normal. Superficial reflexes are elicited. See here the name of the reflexes, right side and left side. Plantar reflex, root value L5, S1, S2. Then abdominal reflex, then corneal reflex, that is fifth and seventh cranial nerve. Conjunctival reflex, fifth and seventh cranial nerve. Pupillary reflex, that is second and the third cranial nerve. Now we will go further. You can see the deep reflexes, upper extremities, bicep jerk, tricep jerk, and brachioradial jerk, that is supinator jerk. Next is the lower extremities, ankle jerk, knee jerk, and jaw jerk. Of course, jaw jerk is not a lower extremities, but that is the mouth related part. Then conclusion, all reflexes are normal, not exaggerated, and not diminished. Now the question and answers in the examination. The first question will be asked by the examiner to the student. What is rigidity? Name the different types of rigidity. So answer will be from the student. Rigidity is defined as a condition of muscle where resistance is felt throughout the passive movement. There are different types of rigidity. First is clasp knife spasticity. In this type of spasticity, resistance is felt during passive movement only initially and then suddenly lost due to the elicitation of end-on reflex. This is seen in decorticate and decerebate rigidity. Next is a lead pipe rigidity. In this type of rigidity, resistance is felt throughout the passive movement. It is seen in the basal ganglia disorder like Parkinsonism, lead pipe rigidity, lead pipe rigidity, Parkinsonism, lead pipe rigidity, Parkinsonism. Okay, cog wheel rigidity is the next type. In this type, resistance is felt intermittently, thus causing the jerks during the passive manipulation. This is because of tremors which get unmasked during passive manipulation. This cog-wheel rigidity is also seen in Parkinsonism. So in Parkinsonism, either lead pipe rigidity or cog-wheel rigidity will be present. Now next question, compare the UMN and LMN paralysis, upper motor neuron and lower motor neuron, from brain to spinal cord, upper motor from spinal cord to the extremity or effector organ, that is LMN, lower motor neuron. Best examples of upper motor neuron is a hemiplegia and lower motor neuron is a poliomyelitis. So in UMN, hypertonia will be there. In LMN, hypotonia will be there. Tone will be more, tone will be less. In UMN, no wasting of muscle. But in LMN polio, wasting of muscle is remarkable. In upper motor neuron, superficial reflexes are absent. LMN also, superficial reflexes are absent. In upper motor neuron hemiplegia, Babinski's sign positive. In meningitis also, LMN, there is no question of that. In upper motor neuron, deep reflexes are exaggerated. In LMN, deep reflexes are absent. In UMN, group of muscles are affected. In LMN, usually individual muscle is affected. In UMN, no trophic changes. In LMN, trophic changes are observed. In UMN, clonus is present. In LMN, clonus is absent. Now, third question in the examination, when is Babinski's sign present? Not in pathology, normal individuals. Babinski's sign, plantar reflex, is present physiologically. Number one, infants below the age of 18 months before the pyramidal tracts become myelinated. And second, during the deep sleep in adults, Babinski's sign may be present. Next, fourth question. In the examination of motor system examination, what is the mechanism of exaggerated deep reflexes? Normally, the lower motor neuron is under inhibitory control of upper motor neuron. Thus, UMN restrains the overactivity of LMN. In case of UMN paralysis, this restraint is lost, leading to the overactivity of lower motor neuron. Thus, the deep reflex become exaggerated as a result of this particular phenomena. Next question, what is Gendrasik maneuver and what is the importance of it? Gendrasik maneuver, that is reinforcement, is carried out if the deep reflexes cannot be obtained ordinarily. In apparently healthy individuals, a reflex may not be elicited either from hyper or from hypotonicity of the muscles. Anxiety may unconsciously create hypertonicity in muscles and fear may cause over relaxation. The act of reinforcement, that is a Gendrasik maneuver, brings the tone to the optimal level. Gendrasik's maneuver consists of hooking the flexed fingers of hands and pulling them apart while the reflex is being elicited. The explanation offered for the utility of this procedure are, according to some experts, the muscular effort in upper extremity increases the muscle spindles in the leg and increases the tone of the optimal level, while according to the others, the efforts, particular maneuver, Gendrasik maneuver, divert the subject, that means the patient's or volunteer's attention, and that is why causes the relaxation of hypertonic leg muscles. Other similar procedures like Gendrasik maneuver, that is clenching the fist or teeth, clenching. This is another type of Gendrasik maneuver, and grasping firmly the arm of the chair where the patient is sitting or side of the bed. Next, sixth question related with the motor system. Why superficial reflexes are lost in upper motor neuron paralysis? Answer will be superficial reflexes result from the activity of element of spinal cord, which in turn are guided and modified by UMN. They possesses an additional superimposed cortical pathway. Impulses ascend to a parietal areas of the brain and have connections with the motor centers in the cortical areas. As the cerebral arc, which is involved in superficial reflexes, is damaged, superficial reflexes are lost. So give the reflex arc of the following reflexes. So for example, collinear reflex, afferent is a trigeminal nerve and efferent is a facial nerve. In conjunctival reflex, trigeminal nerve is afferent and facial nerve is efferent. In pharyngeal reflex, glossopharyngeal is afferent and glossopharyngeal vagus and accessory are efferent. In palatal reflex, glossopharyngeal is afferent and glossopharyngeal vagus and accessory are efferent. So this is all about motor system examination. My dear friends, Ayurveda Academy has a team of expert doctors. If you need paid online consultation, you have to just WhatsApp on 92268 My dear friends, one disclaimer, this video is an information video. Whenever necessary, you must take the consultation of your family doctor. My dear friends, thank you very much. I wish that you are getting little bit benefited by this sharing of my knowledge. If you feel so, please write in the comments and don't forget to like and share this video and subscribe my YouTube channel to give the boost to Dr. Deshpande. I wish all the best, take care and see you in the next interesting video. Thank you very much. All the best.